Hi students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. So in this session, I'm going to discuss all high yielding MCQs. So as our exam is near, so I try to keep some of the high yielding MCQs which I'll be discussing in this session, right? So I am Dr. Ramyasri, your Obgyn Guru. So your NEET is near, right? So give your 100%. Keep studying, keep solving more and more MCQs. At any point of time, if you have any queries, always feel free to contact us. So you can always post your queries in the DBMCI Facebook group or any of the Telegram groups, right? So let us see the first question. Dye test for fistula, all are true except. So first and foremost, let us understand what is this dye test. So the most common fistula is a vesicovaginal fistula. So dye test is used to differentiate where is the problem in the fistula, where is the connection. So dye test is used to differentiate which type of fistula we are dealing with. So first you fill the bladder with methylene blue dye. So you fill the bladder with methylene blue dye, and once you fill the bladder with methylene blue dye, so once you fill the bladder with methylene blue dye, you keep 3 swabs in the vagina. If upper swab is wet by urine but not by the dye, then there is a connection between the ureter and the vagina. So it is a uretrovaginal fistula. So if uppermost swab is wet by urine but not by the dye, then there is a connection between the ureter and the vagina. That is uretrovaginal fistula. So if middle swab or the upper swab is wet by blue color, and then it is a vesicovaginal fistula. So usually many books give middle swab. So middle swab or the lower swab or the upper swab gets wet. So middle and upper swab gets wet. Obviously when upper swab and middle swab is getting wet, the lower swab is also going to get wet, right? So when all middle and upper swab is getting wet by dye but not by urine, then it is a vesicovaginal fistula. If lowermost swab is wet by dye, then it is a uretrovaginal fistula. Right? So now we'll see the question. If a middle swab is stained with dye, the diagnosis is vesicovaginal fistula. Right? It is correct, right? So if middle swab is stained with dye, it is a vesicovaginal fistula, is a correct statement. If lower swab is stained with dye, the diagnosis is uretrovaginal. Yes, if lower swab is stained with dye, the diagnosis is uretrovaginal. That is also correct. Uppermost swab stained with urine but not with dye, and lower 2 swabs are dry. Diagnosis is uretrovaginal. Yes, this option is also correct. So when upper swab is stained with urine and middle and lower swab are not stained, then it is a uretrovaginal. That is also a correct statement. If the middle swab is stained with dye, the diagnosis is genuine stress incontinence. The fourth statement is absolutely wrong. So what is genuine stress incontinence? So stress incontinence is whenever there is a rise in intra-abdominal pressure because of the urethral hypermobility or the proximal urethra and bladder neck going below the urogenital diaphragm. So whenever there is a rise in intra-abdominal pressure, that is when patient is coughing, laughing, little amount of urine coming out, is called as genuine stress incontinence. So genuine stress incontinence is mainly a clinical diagnosis, as well as you have urodynamic studies which can prove this. That is when you see intraurethral pressure. Normally always intraurethral pressure should be more than intra-abdominal pressure. But when intra-abdominal pressure is more than intraurethral, then it is a stress urinary incontinence. So stress urinary incontinence cannot be differentiated by 3 swab test. So 3 swab test is mainly used to differentiate the type of fistula. Most common type, I'll tell you some. See, now we are near the exam. We should be like very crisp and clear. It is like that Sprite, no bakwas, only Only Sprite like that. So now we are come to a point where everything should be crisp, and any topic when you're revising, it should be a 1 minute revision. That's all. So vesicovaginal fistula is the most common. So vesicovaginal fistula mein the most common cause of VVF in India. The most common cause of VVF in India is obstructed labor, whereas the most common cause of VVF in developed countries is most common cause of VVF in developed countries is post-hysterectomy. Right? Next, clinical picture. So as there is a connection between the bladder and vagina, all the urine is continuously coming out through the vagina. So there will be continuous passage of urine and there will be no normal micturition. Continuous passage of urine and there is no normal micturition. Normal micturition is not preserved here. So diagnosis, you can diagnose it with cystoscopy. Investigation of choice is cystoscopy. So 3 swab tests will only differentiate between the type of fistula. It is not going to help you to it is not the investigation of choice or the diagnostic test of choice. Cystoscopy will tell you how far how many fistulas are there, how far it is from urethra, how big it is. All that can be found by cystoscopy. Now coming to the treatment is the 3-layer technique or the Lascaux technique. So you remove the fistular tract and then repair the bladder in 2 layers and repair the vagina in 1 layer, right? And timing has been asked many times as an MCQ for vesicovaginal fistula, guys. So timing of vesicovaginal fistula, it should be performed within 24 hours. If detected within 24 hours, repair immediately. If detected within 24 hours, repair immediately. If detected after 24 hours, then you repair after 6 weeks. And if it is a radiation fistula, then you repair after 12 months. So you have to repair after 1 year because the tissues are very fragile here. One MCQ which has come in the last NEET was post PVF repair, when can they have intercourse and when they can conceive back. So post PVF repair, they can have intercourse after 6 months and they can get pregnant. So pregnancy after 1 year. They can conceive after 1 year. So these are the key points which you should remember as per the vesicovaginal fistula. Okay. Let's go to the next question. A primigravida who is 10 weeks pregnant is complaining of slight vaginal bleeding and occasional abdominal colic. So there is slight bleeding as well as slight pain also. So this is more in favor of as per now. Okay. What are the DDs running in your brain? Ultrasound shows a live singleton pregnancy corresponding to her LMP. Very good. She is worried about losing this pregnancy and asks for any medication to help to keep the pregnancy. She can start oral progesterone therapy. She can start a combination of oral and vaginal progesterone as it is more effective than single therapy. She should start a combination therapy if she gets severe colic. There is no strong evidence to recommend the use of any progesterone therapy. So first and foremost, what is the diagnosis here? So the diagnosis here is threatened abortion. Right? So the diagnosis is threatened abortion. Normally, whenever we have threatened abortion, we always it is threatened abortion because she is having amenorrhea. She is having mild bleeding and mild pain. Right? And scan is normal. So in our clinical practice, for her, we'll give her rest as well as we'll give her progesterones also. So in our practice, yes, we give progesterones. But what is the answer for this? So definitely most of you are thinking the answer might be either A or B or C. But When you have a threatened abortion, there is no role of progesterone. There is no strong evidence to recommend the use of progesterone therapy. See, whatever we do is according to the evidence. See, many times we tend to see such MCQs. Actually, in our notes also, if you see, we just give wait and watch. Bed rest also has no role. Bed rest also has no role. Indeed, bed rest increases the risk of deep vein thrombosis, as well as there is no role of progesterone. The role of progesterone is only in one thing. So, role of progesterone is for prevention of preterm labor in patients who already had once preterm labor. So, in prevention of preterm labor in a patient with previous preterm labor. So only there is a definitive role of progesterone. In our practice we give, but as per the evidence and for your MCQ, you have to go with there is no strong evidence to recommend the use of progesterone therapy. Okay. So I'll also show you what our new Williams also says. So once the threatened abortion is diagnosed, observation is the norm. You can give acetamino-based analgesia that will help in relieving the cramps. The randomized progesterone trial in spontaneous miscarriage, PRISM trial, found no advantage to progesterone supplementation to lower the miscarriages. Bed rest also does not improve outcome, and it just increases the risk of deep vein thrombosis. So you have to counsel them against the intercourse until the bleeding subsides. Apart from that, nothing else to be done. Understood, guys? So I think this was a nice question, which is usually, this is not something which we don't know, but this is a pattern of framing which you can expect in your exams. So I think we should be prepared for some questions like these also. Okay? Right. Let us go to the next question now. A 43-year-old mother of 5 children, para 5, living 5, very good, complains of a 5-year history of progressive, 5 years she's getting, progressively heavy periods that have failed to respond to medical treatment. So transvaginal ultrasound scan performed in the proliferative phase shows a normal pelvis with a regular endometrium of 14 mm. So whenever you have an irregular bleeding or heavy bleeding, or if you have a woman with postmenopausal bleeding. So irregular of heavy bleeding, and if she is premenopausal, and if ET is more than 12 mm, your next step should go for endometrial biopsy. Endometrial biopsy. And if she is on tamoxifen therapy, then ET more than 8 mm, you have to go for endometrial biopsy. And if she is on, so if she is premenopausal, ET more than 12 mm, you have to go for endometrial biopsy. And if she is on tamoxifen therapy, ET more than 8 mm, you have to go for endometrial biopsy. And if she is postmenopausal, and ET is more than 4 mm according to ACOG, and ET more than 5 mm according to FIGO, then also you have to go for endometrial biopsy, right? Again, in endometrial biopsy, the investigation of choice will be office endometrial biopsy. So where we use that endometrial pipellae or office endometrial pipellae biopsy, where we use that endometrial pipellae or Vabra aspirator, right? Next, gold standard will be hysteroscopic TNC. Gold standard is hysteroscopic DNC, right? You can also do hysteroscopic DNC as a first line when it is a nulliparous woman, or when patient is on a tamoxifen therapy, or if there is a focal thickening, right? So now if we go back here, so here the ET is 14 mm. So here the ET is 14 mm. So as the ET is 14 mm, so obviously it is thickened endometrium. So what should be your next step? So go for the investigation of choice. So you will definitely not do hysterectomy just based on increased ET. Hysteroscopic DNC is gold standard, but they are not as gold standard, or they have not tell anything. But so obviously we're expecting what will be the next step. So next step, ash is paraphi living phi, or os will be little open itself. So aram se you can do pupilla endometrial biopsy. See, always first try with pupilla endometrial biopsy. If that doesn't work, then you have to go for hysteroscopic DNC. Or when you have a nulliparous os, or if patient is on tamoxifen, or if there is a diffuse swelling, then you can directly go for hysteroscopic DNC. Now, what is the advantage of pupilla endometrial biopsy? So, pupilla endometrial biopsy is a OPD based procedure. It's an OPD based procedure, right? So it does not require any admission. It does not require any anesthesia, right? It does not require any anesthesia. And there are no side effects. It doesn't require cervical dilatation also. So those are all the advantages which we have with the pupilla endometrial biopsy. So that is why that should be considered as an investigation of choice after the ultrasound. Okay? Right. Coming to the next question. The midwife in the early pregnancy assessment unit asks you to review a woman who has 7 weeks amenorrhea, but the previous and current ultrasound could not locate the pregnancy. The human chorionic gonadotrophin increased from 800 international units to 600 international units after 48 hours. The woman is fit and well with no signs or symptoms. What is your next plan? So the woman is actually 7 weeks of amenorrhea. So ideally when woman is 7 weeks of amenorrhea, you should be seeing the gestational sac, right? So because on ultrasound, by 4 weeks plus 5 days, you will normally see the gestational sac. By 5 weeks, you will see the yolk sac. By 6 weeks, you will see the fetal pole, and by 6 weeks later, 6 weeks, you will see the fetal heart rate. So by 7 weeks, you should definitely see a gestational sac with fetal heart rate. But in this question, although it has been 7 weeks, they are not able to see the gestational sac. And beta HCG has increased from 800 to 1600 after 48 hours. So the woman is fit and well with no signs and symptoms. What is your next plan? So this is a case of pregnancy of unknown location. So whenever you have a patient with pregnancy of unknown location, you have to do serial beta HCG monitoring. So when you do serial beta HCG monitoring, if the rise in beta HCG serial beta HCG. So first and foremost, when you have a pregnancy of unknown location, you have to check for the beta HCG levels. If beta HCG levels are less than 1500, so that is called as the discriminatory zone. So beta HCG levels less than 1500 international units per liter, your next step will be serial beta HCG monitoring every 48 hours. So when you are doing the serial beta HCG monitoring every 48 hours, if there is rise in beta HCG, if there is rise in beta HCG by 63%, then it is an intrauterine pregnancy. You can just wait and watch. If there is rise in beta HCG more than 50% but less than 63%, then it is an ectopic pregnancy. And if there is a fall in beta HCG, then it is a missed miscarriage. But here the gestational sac is not at all formed. So this is called as biochemical pregnancy. So it is a pregnancy which is positive only on the scan, only on the beta HCG, but you don't have the actual pregnancy. So you call this as biochemical pregnancy. When you have a biochemical pregnancy, you don't require to do anything, but ectopic you have to manage either medical or surgical depending on the other categorization. So when the rise in beta HCG is more than 63%, it's an intrauterine. In near time, yes, I do tell all my students this is one of my favorite concept, and in near time you are being getting these concepts as MCQs both for FMG as well as NEET PG, guys. So last NEET you got a question from this, even in the INECET, right? So the woman is fit and well with no signs or symptoms. What is your next plan? So ultrasound scan with 4 to 7 days, ultrasound scan after 14 days, ultrasound. So as the beta HCG is rising from 800 to 1600, so it has doubled, so it has risen 100%. So as there is 100% rise in beta HCG, what should be your next plan? So ultrasound scan within 4 to 7 days, ultrasound scan after 14 days, ultrasound scan after 9 days, requires a serum progesterone blood test. So whenever beta HCG is more than 1500, you will definitely see a sac. So you can just do the ultrasound within next 4 to 7 days, right? If the beta HCG would have become 500, then it is a biochemical pregnancy. So you can just repeat the beta UPT after 2 weeks. No need to do anything. If the beta HCG becomes somewhere around 1000, then the drop is not, then the rise is not 50%. Then what you would have done? You would have just, you have to treat it as ectopic pregnancy. Okay. Next question. A woman attends the urogynecology clinic with symptoms of stress incontinence that have not responded to conservative measurements. She is keen for surgical intervention but wishes to avoid synthetic meshes and tapes as she read they have adverse reports in the media. What is the management? So I told you stress incontinence is whenever there is rise in intra-abdominal pressure, there is leakage of involuntary passage of some amount of urine outside, right? So why do we have stress incontinence? So the concept for the stress incontinence is, so normally the bladder neck and proximal urethra are above the urogenital diaphragm. So normally the proximal neck, the proximal urethra and bladder neck are above the urogenital diaphragm, right? But what happens in the patients with stress incontinence is the bladder neck and proximal urethra have passed below the urogenital diaphragm. That is why whenever there is a rise in intra-abdominal pressure, the urogenital diaphragm closes. But the urine which is present in the bladder neck and proximal urethra, this still comes out, right? So what you should do, you should pull this bladder neck and proximal urethra above the urogenital diaphragm. So you should pull the bladder neck and proximal urethra above the urogenital diaphragm, right? So there are different surgeries to do this procedure. All the surgeries which are given in option are the methods to do this. So TVT and TOT, they are tension-free slings. Transvaginal tape, you have a needle with the Marcelin tape. So you pass from one side of the vagina and you come out from the other side of the vagina and then you cut it. So these tape, So this tape will be present just below the urethra. So this tape will be present just below the urethra. So whenever the urethra is trying to come down, whenever there is a rise in intra-abdominal pressure, this tape will prevent the urethra from coming down. And that's how it protects. It prevents the stress incontinence to happen. Same with the transobturator tape. Transobturator tape also, but here it is coming out from one foramen to the other foramen, right? But in the question, they told she wants to avoid synthetic mesh. The best surgery as of now with the best results is TOT compared to TVT. But earlier it was the Birch colpo suspension. So Birch colpo suspension may you are going to anchor the paraurethral tissues. You want to anchor the paraurethral tissues to iliopectinate ligament. Iliopectinate ligament. So if they would have asked me what is the best surgery, I would have gone with TOT. But here the patient is not willing for TOT and she doesn't want meshes. So that is why the next best surgery will be Birch colpo suspension. So that is why my answer will go with Birch colpo suspension. Now coming to the MMK, Marshall-Marchetti Krantz. Marshall-Marchetti Krantz. Marshall-Marchetti Krantz. Marshall-Marchetti Krantz, here you are tying the paraurethral tissues to periosteum of pubic symphysis. Periosteum of pubic symphysis. So as you are tying it to periosteum of pubic symphysis, there is a side effect of, periosteitis. Periosteitis. Okay. Let's go to the next question. A 90-year-old woman with hypertension and type 2 diabetes presents with worsening uterovaginal prolapse that is not being controlled with pessaries. What is the management? So here, extreme age group, definitely not fit for major surgeries. Ideally, old OD, when the family is complete, we go for vaginal hysterectomy. But here, she is extremely old age group, 90 years. And she has hypertension and type 2 diabetes. I would not like to go for some major surgery, right? So as she has worsening uterovaginal prolapse and this is not being controlled with the shelf pessaries. So what is the management which you will do? It is a Leafold's colpoclesis, right? So that is total colpoclesis. So what we do here is we push the uterus inside and we obliterate the anterior and posterior walls of vagina. We push the uterus inside and then we obliterate the anterior and posterior walls of the vagina, right? So in Leafold's operation, and then what we do is we leave little gaps on either side of the vagina so that any secretions from the uterus can come out through these gaps. So that any secretions from the uterus can come out through these gaps. Okay. We also have Good-Powell's operation. So Good-Powell's operation means also you are pushing the uterus and the cervix inside, but you are going to obliterate the anterior and posterior vaginal walls in a triangular fashion. It is, and you're not obliterating the entire vagina, only half of the vagina you're obliterating. So this is a partial colpoclesis. Okay. Sling surgery is usually preferred in nulliparous prolapse. Right? So here the answer is Leafold's. Ward Mayo surgery is family complete and those who are fit for surgeries. So like 50 years, 60 years, and Ward Mayos includes vaginal hysterectomy plus anterior colporrhaphy plus posterior colpoperineorrhaphy. So if you have a nulliparous woman. So the take home message here is, so for the urogynecology, so if you try to understand, I have tried to cover the entire urogynecology through these MCQs, right? So to summarize, if you have nulliparous woman, best surgery will be sling surgery. Purandare or Shirodkar or Kannas or Virkul. So Purandare, P for Purandare, P for posterior rectus sheath. Cervix is tied to posterior rectus sheath. Shirodkar, S for Shirodkar, S for sacral promontory. So cervix is tied to sacral promontory. Kanna, K for Khanna, K for Kamar. The bony prominence in the Kamar is ASIS. So here the cervix is tied to the anterior superior iliac spine, right? And Virkud is a combination of Shirodkar plus Purandare, as Shirodkar has sigmoid colon obstruction. Next, if you have a young woman, family complete, for example, 30 to 35 years, family complete, para 2 living 2 with prolapse, then I don't prefer doing vaginal hysterectomy for her. I will do Fothergill's operation for her. So what is Fothergill's, guys? A quick recap of Fothergill's. So Fothergill's में you will do first preliminary DNC to rule out any cancers or hyperplasias. Then you will amputate the excess cervix, and then you advance the transverse cervical or cardinal ligaments which are lateral to in front of the cervix, followed by you do anterior colporrhaphy and posterior perineal. Fothergill's operation is also called as Manchester's operation. So here you are preserving the uterus, and as her family is complete, even there is cervical incontinence, not to bother, right? Next, if you have old woman, family complete, then vaginal hysterectomy. Extreme age, unfit for major surgeries. For them, like in the just now case which we have discussed, for them we do, so extreme age, unfit for major surgery, for them we will do good. First you try with pessary. If pessary does not help, then you will go for, if pessary does not help, then you will go for the Leafold's colpoclasis. Next, if you have one stress incontinence, I already told that also you write it in as a table. So I want you to keep this in your last minute revision table. So in the entire chapter of urogynecology, this much is very important for you to revise what surgeries for what. Most of the time they ask you the surgeries itself. Okay. For stress incontinence, TOT followed by TVT followed by Birch. And for vesico-vaginal fistula, it is the Lascaux technique. So I think this slide is perfect for you to revise all the surgeries for the most important surgeries for the prolapse, right? So whatever I've discussed, based on that, we have a question here. A young nulliparous woman has a 3rd degree uterovaginal prolapse without any cystocele or rectocele. There is no stress incontinence. The uterus is retroverted, UCL is 3 inches, all other symptoms are normal. The best treatment plan for her will be, so as it is a 3rd degree uterovaginal prolapse, she cannot conceive with uterus and cervix hanging outside, right? So I told you the nulliparous woman, what is the best surgery we have? Sling surgery. So that is why your answer will go for C, Shirodkar abdominal sling, right? Next question. Where is the following instrument used? Nowadays we do get many questions on the instruments. So what is the instrument which you're seeing here in the image? So if you see, there is a beveled end. Actually, there will be an eye also here. I don't know how clear it is visible to you, but there will be an eye also. So there is a spring action. There is a spring action. So you normally hold it like a dart. You normally hold it like a dart. And then you lift the abdomen and then you pierce through it. So this is used to create the pneumoperitoneum, and this is nothing but the varus needle, right? So this is new. This is used to in the laparoscopy to create the pneumoperitoneum. The gas used for pneumoperitoneum is 6 carbon dioxide. The pressure which has to be achieved is 15 mmHg, right? And how do you know that you have entered the peritoneum only? So while you have to hold it like a dart, and then you go 90 degrees to the abdominal wall, paraumbilicus or through umbilicus 90 degrees to the perpendicular to the abdominal wall, and it makes an angle of 45 degrees with the pelvis. It makes an angle of 45 degrees with the pelvis, right? Next, while you're entering the abdomen, you hear two clicks. So first click is when you pierce the Schechter sheath. Second click is when you pierce through the peritoneum. So when you hear two clicks, it means that you have entered the abdominal cavity, peritoneal cavity. So then you can do the hanging drop test. So as the abdominal cavity or the peritoneal cavity has a lot of negative pressure, when you put one drop of normal saline, you will see that the normal saline gets sucked inside, right? So this is about the varus needle. So this is the instrument which is used to create a pneumoperitoneum in the laparoscopy. Next question. A 29-year-old woman, always when you have a very big question, the last part of the question will be very important as well. Please remember the age and parity. And her partner are seen in gynecology with primary infertility. Okay. They stopped using condoms since 2 years and have had regular intercourse since then. So it is a primary infertility since 2 years, right? The partner has no previous medical history of note. He drinks approximately 8 units of alcohol per week and does not smoke. He works as a manager in a hotel. The woman also has no specific previous medical history except for appendectomy. That's fine. Her periods occur every 31 to 46 days. This is not acceptable. So she has irregular cycles. So probably she's having an ovulation. And can be heavy at times but not painful. Yes, so that confirms that we are dealing with an anovulatory cycle. So whenever you have a prolonged amenorrhea followed by heavy bleeding and a painless cycle, that is more favor of PCOD. There is no intermenstrual or postcoital bleeding. She always had normal smears and has never had any sexually transmitted infection. She takes no medication, drinks approximately 6 units of alcohol per week, does not smoke. So basically we had only 4 points which are important in this entire big question. So when you get a big question on like this, don't give up on the question. Have a quick glance. Most of the time they'll be easy. And this is the scan which you have done for her. What is the next step you want to do for her? Metformin, ovulation induction with letrozole, ovulation induction with clomiphene citrate, husband semen analysis. So this is the pearl of chain appearance. This is a beautiful pearl of chain appearance, right? Yes, obviously all of you will now think either ovulation induction with letrozole or with metformin. Now I ask you one thing. So if you have answered A or B, you fell in the trap, guys. So I'll just see the question here. It's a primary infertility. Yes, I agree with that. There is a PCOD here in the patient. But before you start ovulation induction, don't you think you have to evaluate the male partner also? If male partner has azoospermia, you're going on giving ovulation induction drugs. Will there be any use? So whenever you have an infertility patient, you have to evaluate both male and female partners. See, such small points we should not miss, right? So you have to evaluate both male and female partners before you start treating her with ovulation induction. So as I specifically asked, see in the exam, if they didn't ask you the next step and they asked what is the management you would like to do for her, then 100% go for ovulation induction with letrozole. So PCOD patient, so try to understand the questions and the manipulations which it has, and then try answering every question. So here, if it is a direct like a PCOS and they ask you what is the management for PCOS with infertility, the best drug which you can give is always the letrozole. So then undoubtedly the answer will go for letrozole. Okay. But here I am asking you very clearly that I have evaluated the female. I didn't evaluate or do any test for the male. So what is your next step? First do semen analysis for the male. If that comes normal, then you can just go only with ovulation induction with letrozole. I hope you all enjoyed the twist in the question. So the answer here is D. The answer here is D, right? Next question. A 24-year-old woman with her 35-year-old partner has been referred to the infertility clinic because of 2 years of primary infertility. Woman has irregular menstrual cycles. 24-year-old with 35-year-old partner has been referred to the infertility clinic because of 2 years of primary infertility. The woman has an irregular menstrual cycles every 2 to 4 months and her partner's semen analysis is normal. See, here they clearly gave that partner's semen analysis is normal. So again, this looks like a PCOD itself. But here they declared that partner's semen analysis is normal. Woman BMI is 26. There is no significant past medical history. Investigation has confirmed the diagnosis of PCOD. The couple have not achieved a pregnancy despite a 6 months course of clomiphene citrate with evidence based on day 21 with evidence of ovulation based on day 21 progesterone concentration and ultrasound scanning. So what is the next step which you want to do for this patient? Again, this is one of my favorite question, I want you to develop this approach to the question and this way of thinking for the question. Some nowadays in INECET, we tend to see some questions like this. So if you see here, and we do see lengthy questions, we are not anymore seeing the single liners, right? So again, a beautiful question, guys. So if you understand the question here, she is a case of PCOS. Husband is also normal here. Unlike the previous question where we didn't evaluate the husband, here very clearly they have given that husband semen analysis is normal. Right. Next they have asked ki couple has not achieved a pregnancy despite a 6 months course of clomiphene citrate with evidence of ovulation. So they have not got pregnant even though you have given 6 months of clomiphene citrate, but she's been ovulating. So then what should be your next step? Now many students jump and answer it is IVF. Guys, she is ovulating. By IVF also you make her ovulate itself. So why do you want to do IVF before trying to evaluate? Don't you want, before you jump to IVF, I agree with 30 to 40% are the ovarian factors for infertility. So before we jump to IVF, don't we require to evaluate for the tubal factors also? Because all this time we have been thinking it is only PCOS causing this problem. But although we have given clomiphene citrate, she didn't conceive. So before I do anything further, like that is before I do IVF, I would like to evaluate the tubes also. So I will go for laparoscopy and dye test. Right? So if tubes are also blocked, then I would like to go for IVF. Right? Yes. A 30-year-old nulliparous woman complains of 6 months history of deep dyspareunia that has not responded to medical treatment. Pelvic ultrasound scan shows a 6 centimeters complex right ovarian cyst. What is the management you want to do for her? Laparoscopic cyst aspiration, laparoscopic cystectomy, laparotomy and oophorectomy, GnRH analogs. So what is your diagnosis here? So whenever the question tells dyspareunia, dysmenorrhea, pain as a predominant symptom. It is nothing but your endometriosis. And here the 6 centimeter complex cyst is nothing but the chocolate cyst. So the classical triad for endometriosis is DID, Dance India Dance. Dysmenorrhea, secondary dysmenorrhea or progressive dysmenorrhea or congestive dysmenorrhia. So dysmenorrhea, infertility and dyspareunia. So dysmenorrhea, infertility and dyspareunia, right? So 6 months history of deep dyspareunia and pelvic ultrasound is showing a 6 centimeters complex right ovarian cyst. So what should be your next further management? So the further management will go for, so whenever the cyst size is less than 3 centimeters, you can aspirate and coagulate the cyst wall. But as the cyst size is more than 3 centimeters, your management will be going for removing the entire cyst. That is the laparoscopic cystectomy, right? Okay. And as she wants to conceive also. Next question. A 48-year-old woman with intermenstrual bleeding for 2 months. Episode of bleeding occurs in any time in the cycle. This is usually fresh red blood, much lighter than a normal period. So there is an intermenstrual bleeding which is fresh red blood, much lighter than a normal period. It can last for 1 to 6 days. There is no associated pain. Right? She has no hot flushes or night sweats. She is sexually active and has not noticed vaginal dryness. She has 3 children and has used progesterone only pill for contraception for 5 years. Her last smear was 2 years ago and all smears have been normal. She takes no medication, has no other relevant medical history. So what is the management you want? What is this? Identify, right? Okay. So he's trying to rule out by the history. So there is an intermenstrual bleeding which is fresh red blood and much lighter than a normal period. And he's ruling out atrophic vaginitis by telling that she doesn't have any menopausal symptoms. He's ruling out the cervical ectropion and the cervical cancer also by telling her smear was normal, right? And there is a homogeneous hypoechoic mass in the endometrium. It is a complete whitish homogeneous hyperechoic mass in the endometrium. So this is not cervical malignancy because her smear was normal last 2 years. She is not on any pills. Normally when they are on OC pills, there can be eversion of the columnar epithelium outside, causing the cervical ectropion. So this is less likely to be cervical ectropion. Now I don't see a polyp in the cervix. I see the polyp in the endometrium. So this is an endometrial polyp. So endometrial polyp will present you with intermenstrual bleeding, which will be fresh bright blood, little in quantity, right? And usually investigation of choice will be hysteroscopy, gold standard also hysteroscopy, but it is very good, detected well on saline infusion sonography. Treatment here is hysteroscopic DNC. Fibroid will be homogeneous and hypoechoic, so it will be complete black. So this is homogeneous and hyperechoic. And fibroid, you will have peripheral vascularity. So you will see the vascularity from the lateral aspect. But here if you are observing, you will see only one vessel entering into the polyp. So that is called as feeding vessel sign positive. So that is called as feeding vessel sign positive, right? A 24-year-old patient sustains a perineal tear during delivery. On examination, there is a 30% thickness tear of the external anal sphincter. Internal anal sphincter appears to be intact. What grade of tear is this? So, perineal tears, grade 1 perineal tear, only skin is cut. Grade 2, skin plus muscle is cut. Grade 3, sphincter is also cut. So 3A, less than 50% external anal sphincter cut. 3B, more than 50% external anal sphincter cut. 3C, external anal sphincter plus internal anal sphincter is cut. And 4th grade, rectal mucosa is cut. 4th grade is rectal mucosa is cut. Right? So here 30% of the external anal sphincter is cut. So that is nothing but as less than 50% of external anal sphincter is cut, so this will come under 3A. Now remember guys, if you have grade 3 or grade 4, grade 3 or grade 4 perineal tears, if this has to be repaired in OT under spinal anesthesia, and post-op you have to keep her nil per oral for next 48 hours, and then you have to slowly start her on liquid diet and then convert her to solids, right? Because you want that anal, whatever the sphincter which you have treated should heal. And if you have detected perineal tears after 24 hours, now this has become a contaminated wound. So what you will do, you will repair it after 12 weeks, that is 6 months. So now you will repair that after 6 months. So till that you have to divert the fecal matter by doing colostomy, and then you have to let the tissues to heal, and after 6 months you can repair it, right? What type of perineal tear is episiotomy? So episiotomy is a second degree perineal tear, right? So these are some important high yielding MCQs. I'll be trying to post more videos like this. You can tell which topics you are interested so that I can make more questions on that. So keep going through these MCQs what I post, because that will help you to understand how to approach a question and how to answer the question, right? So all the best guys. Take the preparation for the next. So we all know that your exam date has been announced. So March, you're going to have the NEET 2023. It's been officially announced. So, this is a high time where you have to put your soul into your preparation, and it should be like a penance. So give your 100%. So when you look back, you should not tell, I should have read little more, I could have done it. So that little more which you want to do later, do it now. Don't give any opportunity to tell yourself, I should have done more better. So satisfy your soul by doing the best what you can do. Give your 100% as the time is limited, right? So thank you so much guys. Thank you so much. All the best. If any queries, always feel free to message guys. Thank you so much.